I tell you. So now the question of problem in amblyopia is not in the eye. Eye may have problems, but that is not the cause of not being able to see well. Not being able to, because if the eye has a refractive error, you correct the refractive error, the child should see normally, but child is unable to see. So where is the problem is the question. So we have been blindly patching the normal eye, hoping that the amblyopic eye will start seeing with the fovea. It does not work like that, because foveal fixation is an active process and it is not a passive process. Just because I close the eye doesn't necessarily mean I fixate with the fovea. The brain has to work hard to fixate. You understand? So this is where we have been going wrong. We have been doing patching the eye and hoping the child's vision improves. It does not. It does not improve. Even after months of patching, it does not improve. Supposing the child, what happened? You have not amblyopias, they said. It's useful in the treatment of intermittent divergent squint. Yes, 100% I am confident that it works in intermittent divergent squint, because in intermittent divergent squint, the problem is in the attention center in the parietal lobe. And the stimulation of the magnocellular cells stimulates the attention center in the parietal lobe. It's useful in exotropia, which you saw already. It's useful when the stereopsis is lost due to any other reasons, and it is useful to improve hand-eye coordination. Here, it's a little bit of explanation is needed. In the brain, in the frontal eye field area, the hand area comes very close to the frontal eye field area. So whenever the hand moves, the eye follows the hand. Supposing hand moves out, the eye moves out. Hand moves in, the eye moves in. It closely follows the movement of the hand. So much so that while doing the MRI or while doing the EEG, you cannot differentiate whether hand-eye area moves first or eye area moves first. They move very close to each other. So whenever you move the hand, the eye, obviously the area gets stimulated. From the frontal lobe, fibers come down to the occipital lobe. These fibers are called as top-down fibers, because the frontal lobe is top, occipital lobe is bottom. So from the top, bottom, the fibers come. These fibers go beyond the synapse in the 4C beta. So I'll come to that in a few minutes. So there are a number of other indications like nystagmus. Nystagmus, it works very well. I had a patient of 40-year-old who came, who couldn't fit the contact lens. So he said, I can't do, and with the glasses his vision was not improving. After orthoptek, he could put the contact lens himself. And he was very happy with that. He was I will come to that also. What is the hypothesis behind fourth nerve improvement, sixth nerve improvement, and nystagmus? All those three, I will come to that. It can be used in decreased vision due to unknown causes. You don't know what is the cause. Try it out. No harm in trying. It is non-invasive. No harm. If it improves, she showed you in macular dystrophy, the vision improved. I have seen myself one patient from Saudi bought his machine, he took it along with him. I don't know whether he is treating other patients with other kinds of problems, but I sold it to him. I said, okay, you can take it with you. So it improves vision in unknown causes. You can try it out. Optic nerve problem, somehow it improves the vision. These are the places where you need explanation. In the optic nerve problem, the vision improves because the corticogeniculate fibers, the fibers coming from the occipital cortex to the lateral geniculate body, you all assume that it stops there. No, it comes up to the retina. It doesn't stop there. It comes right up to the retina, and therefore the vision improves. That makes sense to me. I have seen cases where the vision improves in macular problems. Somebody said, can this be tried in ARMD? I said, I don't know. I have never tried it. But if you try and vision improves, you report it. I have no problems with that. So these are the other indications which these people gave. Where is that? This presbyopia is a problem actually. Okay, these are the some of the initial users. After 6 months they gave the result. I asked them, what do you think? They said it's a magic instrument and it's a wonder gadget, and I have never seen anything like that in my life before. And you can see their skeptics. These are all the people who are very skeptical about orthoptek. Now, this is where the crux of the problem comes. If you understand this, you understand how the orthoptek works. There are P cells in the center and M cells in the periphery. Whenever they go to LGB, and from LGB, P cells go to 4C beta in the occipital cortex, and M cells go to 4C alpha in the occipital cortex. See, this is the visual dichotomy. They go to different areas. Okay, 4C alpha 1 and 4C beta other one. Temporal cortex, from P cells it goes further down to temporal cortex, because occipital cortex, I say, is like Manmohan Singh. He is unable to analyze any file, he will just pass it on to the high command. You please analyze the file and tell me the result. So occipital cortex forwards the impulses to the temporal cortex, which further analyzes the image and sends information to the posterior parietal cortical area in 7A, which is attention area. Whereas M cells, LGB layers 1 and 2, and it goes to 4C alpha in occipital cortex. This goes to beta, this goes to alpha. From here it goes to superoparietal area. In the superoparietal area, it comes down to again posterior parietal cortical area, which is attention area. So every time you stimulate this, it stimulates this. And from here, it goes back to 4C beta. See how it is stimulated? Every time you stimulate magnocellular cells, the attention area gets stimulated via the top-down impulses. From here, it goes to the occipital cortex back again to stimulate 4C beta as a forward, as a top-down impulse. From this area, it goes to this. Again, from the frontal eye field area, you can see here, frontal eye field area. From here, the fibers come back to the posterior parietal cortical area, and from there they go to again beta occipital cortex. And that's how they stimulate. These are normally existing fibers, top-down fibers. They are normally existing, and they can be recognized on EEG as alpha and beta stimuli or alpha and beta oscillations. From what goes from beta to temporal cortex can be seen as gamma oscillations. So the gamma oscillations and alpha and beta oscillations are connected here. If the gamma oscillations occur within 150 milliseconds, that is, if the alpha and beta coming down from the frontal cortex and from the parietal cortex, they come 150 milliseconds before the gamma oscillations disappear. They improve the fast forwarding of the impulses to the temporal cortex. This is the principle behind orthoptek. The lights which come on and stimulate the P cells must come on at least 150 milliseconds before the next light comes on the peripheral retina. If it comes later, it doesn't work. So how the occlusion works is because of this. That even though you apart the eye, the impulse may be falling on the normal eye at randomly before 150 and randomly after 150. It doesn't work if it falls after 150. It works if it falls before 150 milliseconds. That is the whole idea, and that's where these two are connected. Am I making sense to you at all? Okay, this is another one you can see. Neurotransmitter. Glutamate is the neurotransmitter in the 4C beta. Okay, 4C alpha, 4C beta, everywhere is the neurotransmitter is the glutamate. Glutamate is excitatory in nature, and it is very dangerous to the central nervous system. So glutamate has to be rapidly decarboxylated to make glutamine, which is taken up by the post-ganglion, post-synaptic cells. See, this is where it becomes very tricky in order to understand the synaptic transmission at 4C beta, which is the problem. The problem may be because glutamate is not released, or maybe because a small amount of glutamate is released, or glutamate released is not very good quality. All these things can be cause of decreased vision. So even if you increase any number of impulses going from the retina to the cortex, vision will not improve. This is the mistake we have been making, that we are sending impulses from the retina to the cortex, hoping that some impulses reach the cortex. That is inferotemporal cortex. It should reach not just occipital cortex, it should reach inferotemporal cortex, because the block is in the synapse of 4C beta. Now, how did I know all these facts? Just read through that and then I realized that this must be the reason. Do I have enough papers to show you? The answer is yes. But if I give you that, you will just fall asleep. If you want to fall asleep, that is the best papers to read in neuroradiology and neurophysiology journals. So these are the top-down impulses coming from the parietal area and also coming from the frontal eye field area towards the 4C beta. And here they act as if glutamate is released. And this top-down impulses discharge beyond the synapse. That's how they act so rapidly. And why do they act rapidly? Because beyond the synapse, the top-down impulses stimulate the production of nitrous oxide. And nitrous oxide has 10,000 times affinity towards the heme component, and therefore it stimulates the synapses. And therefore the patients feel subjective improvement within one session. They say, I can see better. It's some kind of magic. It's not magic. It is something to do with the top-down impulses. Okay? So our senior said, Sarvendriyanam Nayanam Pradhanam, which makes sense. You have learned Sanskrit, it makes sense. You have not learned Sanskrit, you have learned English, it never makes any sense, because you can see how the occipital area is connected to every other area in the brain. It's not just occipital retina is connected to occipital cortex. No, occipital cortex itself is connected to thousands of areas in the brain. So when you do fMRI, these are all the areas which get stimulated as soon as you stimulate retina. So you can't imagine retinal stimulation alone improving the vision by patching the eye. These are the things. If you have any more information you want, I think I am almost coming nearer the discussion time. If you have any more questions, any more doubts, you still have plenty of time. You can ask. And if you come closer, I'll show you how it works. Simple, very simple mechanism. You can come in groups, or you can come all of you. Hello, excuse me, friend. Just keep it light is alternating with green light. Can you see that? Wait 1 second. Now you see, red is alternating with green. When you are concentrating here, this comes on. That means peripheral retina is stimulated. Correct? And you move there, this comes on. That means again peripheral retina is stimulated. Now how do you move it there? What makes the brain understand that the red light is there? You understand? Because whenever the peripheral retina is stimulated, the peripheral retina does not have the analyzing capacity. It says, boss, something goes somewhere. I don't know what it is. Where? Here, I am seeing it, but I don't know what it is. Because the peripheral retina has better position sense. Then the fovea says, okay, let me take a look at it. So then the fovea says, boss, you tell me where to go. I don't know where to go. I know I have to go, but I don't know where to go. The brain says, hang on a minute, let me calculate. The peripheral retina and central retina are interconnected at different parts of the brain. They are all interconnected. They are not separate. They are not separate entities. So then the brain looks at the peripheral stimulus and says, okay, you have to move, abduct the eye by this amount and elevate the eye by this amount. And then the eye moves. Because the brain computes the distance between the peripheral retina and the fovea and sends impulses to the motor cortex to say, move the eye by this much. All this information happens within a few milliseconds. It takes more time for me to explain that than for the brain to move the eye. You understand? So the brain moves the eye. So which means that fovea is already aware of what is the object in the periphery, although not fully. So when the fovea focuses, it gets, now I know what it is. But in amblyopia, fovea doesn't know because it cannot pass on the information to inferotemporal cortex due to a synaptic block. When it cannot pass on the information, you can come closer, you can see. Due to synaptic block, inferotemporal cortex is the one which analyzes. So it can't analyze. If it can't analyze, you can't see. Although it is coming up to the synapse, it's not going beyond synapse. If it's not going beyond synapse, it's dying there. So brain doesn't want to get damage due to glutamate, so it suppresses. Therefore, the action potential from the abnormal eye is completely suppressed by the brain. So that even if you close the normal eye, it does not move, it doesn't help. That's why patching we have been following for thousands of years without understanding anything, and blindly we are patching the eye. And somebody told me you have to patch aggressively. What do you mean? You hit the child once before you patch? That is being aggressive, no? So some of the terms you use aggressively patching is because we are not conversant with proper English. They say a lot of things, but in English the problem is each word does not mean what it is meant to mean. It may mean anything. So this is the principle based on which it works. Peripheral, and this is program 1 where you are using the hand-eye coordination. See that? I have to move this wherever the light comes and put it on the light. Can you see that? This is program 1. Here, two things are happening. One is hand is moving to where the light is, like that. Which means that I am moving the eye and the hand at the same time. It improves hand-eye coordination, improves handwriting. In 2 days, the children feel very comfortable. It improves leg coordination also. You'll be surprised how. I'll tell you an example later. But this is how the hand-eye coordination improves, plus the vision improves by doing this. See that? If you do that, even my handwriting improved after doing that. It was very bad. So I started doing that. My handwriting also improved because hand-eye coordination is important for handwriting. And many games is important. This is program 1. Now what you do is you just gently press that. Now it becomes program 2. Here what you do, keep looking at the green light. Ignore the red light. But keep counting the red light. See, if I am looking at the green light, I can still see the red light. I am not moving the eye, covert, but I am still aware of the red light in the periphery. Yes? And I am counting that like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I can count how many times the light comes on even though I am looking at the central light. So that becomes covert attention. The attention of the occipital cortex is drawn to the red light, but the occipital cortex is sending inhibitory impulses via the attention center to the saccadic generation center and forward to the frontal eye field area so that the eye does not move. Which means that during the time you are not moving the eye, still you are stimulating the occipital cortex. You understand the mnemonics of it. So then I realized, is it important to not move the eye? Sometimes you can let the child move the eye also. It stimulates attention. And also, see, 91, 92, 193, they can't count like that. They become very breathless. So count up to 20, then again start from 1, 2, 3, like that. If you count, you know how many times the child is counting and for how long the child is sitting in front of the machine. If you don't count, I don't know for how long the child is sitting in front of the machine and concentrating too. Just sitting in front of the machine is of no use. You must concentrate. It is like taking this and putting it in the book. It doesn't work like that. You have to put effort. It doesn't work. That is exactly the reason why I said in some patients they said they did not improve. The next question I would ask, okay, it did not improve. Is the fovea normal? Do an OCT, particularly Heidelberg OCT. If you do, you will realize that the fovea is hypoplastic. It doesn't work. It does not work. The vision improves up to a point and doesn't improve beyond that point at all in foveal hypoplasia. Then another group of patients where it does not work is in congenital cataract, where if you do multi-point EEG, you realize that the alpha and beta oscillations are reduced. There it doesn't work. The alpha and beta oscillations come from the top-down impulses. And if they are not there, vision will not improve. But nowadays, nobody is doing in India 128, 256 points EEG. You have to do 256 points EEG, then only it helps. To identify those where it does not work. Now, instead of knowing all these things, all you need to know is how to buy it and how to use it. Don't bother about the philosophy behind it. It's my child. I am very happy to describe my child in front of everybody. They'll say, "Kya bakas bol raha hai child ke bare mein?" No, there is no use. Machine counter reh ke kya karoge aap? What we are? No, that doesn't matter. As long as the patient counts 800. Or somebody moves there, he looks, who is very interesting, what is happening there and all. So what? 1,45,000 for Indians. 1,45,000. Yeah, buy it. I will give you this for half the price. Huh? Sunday only I cannot give you today, Sunday. Okay, so this is all there is to this machine, but 1 year of concentrated reading has gone through it. What I have explained to you, you will not find in one place. You need to read multiple journals, then you will find it. Now you have any doubts? You are free to ask. What's the time?
Is it used for specific cases?
No, all cases. Every case you use program 1 because you want to improve the hand coordination. Use program 2 because you want to improve the vision. The program 1 30 minutes session. 15. Every day you have to do it for 2 weeks. Now why 2 weeks is the question. That's a very tricky answer it has got. The nitric oxide released in the synapse. By doing this exercise, in the synapse in 4C beta, nitric oxide is released in the brain. Can you imagine nitric oxide being released in the brain? This has what is called as long-term potentiation effect. LTP it is described as in neurosurgery. That is, it makes this thing to grow back in the brain. Terminals, axonal terminals. And therefore, the effect not only lasts longer, but is sustained. Even after you have stopped the exercise, it's sustained because of long-term potentiation effect. And the long-term potentiation effect does not start for 2 weeks. It starts only after 2 weeks it starts. So minimum 2 weeks you have to do. After that you can cut down. No. You normally occluded for 15 minutes. Then do it with only amblyopicai. And then do it with both the eyes for 5 minutes and do it with the normal eye open only for 5 minutes. What if vision is good in both the eyes? No problem. Do it equally in both the eyes and in each eye equally. Intermittent divergent squint, both the eyes may have equal vision. In which case you do with the right eye 15 minutes, left eye 15 minutes, both eye 15 minutes.
So minimum vision when we going for the amblyoptic, right?
Counting finger.
From 1 meter distance, how will you be able
They
to
will see. For 2 days they won't see.
Okay.
Then they will see.
And so what is the cutoff, like when can we stop? What is the end?
Vision improves, stop.
Counting finger?
Counting finger vision I have seen.
Half feet, 1 feet, I mean, what is the criteria like?
Okay, I'll show you this video. A video दिखाओ भैया. Show me that video. Is it there? Ah, there. ये वाला देखो. Okay, this is the child who is no, ये वाला देखो. हाँ ये वाला. This is a 3-year-old child with intermittent divergent squint, ophthalmologist's niece. And I decided this child cannot point out the laser, the child may look at the laser light. I said, no problem. With the finger, keep eating chips in one hand, and with the finger keep showing the light. See what she is doing? And after 3 weeks, her intermittent divergent squint was reduced to exophoria. She was worried whether we need to operate on her. I said, let's wait for some time. See, this is what I do in very young children. Basically, you need to point out the light. So you point out light like this. Yes. Sorry? I have given a long explanation as to why the eccentric fixation is a misnomer. It's rubbish. To tell you frankly, what you people diagnose as eccentric fixation is all wrong. I try in eccentric fixation, it works equally well. I need half an hour to explain to you the whole process. But it works in eccentric fixation also. Okay, so that's how the child does with, and this one is another child who is happy doing the, you can see that. I had to tell her repeatedly, don't look at the green light in your hand, and see, child does it herself. She comes, sits, puts the occluder herself behind the glasses and starts doing the exercise. You don't need to do anything.
When do you check the vision, sir? Like after 2 weeks?
Sorry, when?
When to access the vision?
Every day before exercise you assess the vision. Every day.
So it's in the vision, some specs. You don't have
Give this here, specs. Yeah. And if the, yeah.
If the patient is not improving,
Check why it is not improving. Do a foveal OCT and see if there is a problem.
how long can we continue, sir, maximum?
Minimum 3 weeks you can continue. If it is improving, it will improve. If it is not likely to improve, you can forget about it. It won't improve.